That looks fantastic.
This is good. Can you guys see my screen?
Looks great.
Okay. So hi, everyone. I'm going to talk about AKI today. Again, my name is Shantheri. I'm one of the hospitalists and nephrologists. I do both services at Mount Sinai West. So AKI is really a vast topic. You know, I wouldn't be doing justice talking about AKI in 50 minutes, but what I'm going to focus on here is to define and classify AKI, know the incidence and prevalence of it, which is very important as you'll see. Know the classification, important on the wards, how to diagnose AKI and management of important AKI syndromes. So what is AKI? You know, KDIGO definition, AKI is either increase in serum creatinine by 0.3 milligrams per deciliter within 48 hours, or an increase in serum creatinine to 1.5 times the baseline that has occurred in the past 7 days, or a urine volume of less than 0.5 ml per kg per hour for 6 consecutive hours. AKI classification, you know, there's 3 important ones, and really for clinical practice, you don't need to know this. You don't need to know what is 1, 2, and 3. If there's one thing that I want you to remember, it is the rifle classification, in which failure is defined as creatinine increase more than 3 or more than 4 with an increase of 0.5 milligram per deciliter or initiation of RRT. Loss is complete loss of kidney function, where a patient is on renal replacement therapy for more than 4 weeks. And most importantly, when do we call it end-stage kidney disease? Is when someone's on dialysis for more than 3 months. I'm not able to move my slides. Okay, here you go. So what is the incidence of AKI? You see it in around 10 to 15% of all hospitalizations, but in the ICU, the prevalence is more than 50%. And this is important to know because any patient in the ICU with AKI and any patient with sepsis, if the patient has an additional AKI, then their mortality is almost 60 to 70%. So I know a lot of you are categorical interns here, and you see patients in the outpatient clinic, and not all AKIs that you see in the outpatient clinic need to be sent to the emergency room or, you know, need to get admitted. So when do you send them for evaluation? So basically stage 1 AKI, which is, you know, if your creatinine has gone up by 0.3 and you don't see a clear cause of it. If you see a patient who was started on an ACE or ARB the week before and you see a jump in creatinine, or was started on Bactrim, or as diuretics were increased, then you don't need to send them to the hospital. You can just cut back on the medications, eliminate the cause, and then wait and see, repeat and watch closely. However, if the AKI is in a resource limited setting, you know, if the patient cannot come for follow-up, you think they're going to be lost to follow-up, it's better to send them for evaluation. Any other AKI stage 2 or stage 3 definitely needs to be evaluated in the hospital or sent to the emergency room. So what you see here is, you know, incidence of AKI over the last 20 to 30 years. This was a paper that came out in 2007. What you see in green is non-dialysis requiring AKI, and the dark green is dialysis requiring. The incidence of AKI has significantly gone up, and so has the incidence of dialysis requiring AKI. However, what you see between 2000 and 2004 here is that the incidence of dialysis requiring AKI has remained steady. That's because around then was when the paper came out that early versus late initiation of RRT and AKI, there's no difference. So people kind of adapted the wait and watch policy and not knee-jerk dialyze them right away. And why is the incidence of AKI increasing? You know, what's changed over these years? One of the main things is diabetes. The risk factor, an important risk factor for AKI is diabetes. And as you can see from 2000 to in the last 15 years, in both in men and women, the incidence of diabetes has gone up significantly. So has AKI-associated mortality. So now what are the causes of AKI? We all know from medical school, there's your pre-renal, renal, post-renal, and this slide kind of summarizes it. You have your pre-renal azotemia, which is hypovolemia, cardiac failure, hepatorenal syndrome, or something in the renal artery or renal vein, can also be pre-renal, because that's before, you have before the juxtaglomerular apparatus. So either a renal artery occlusion or a medium or large vessel vasculitis or renal vein thrombosis. Intrinsic renal, again, you could have something in the glomerulus, you could have something in the tubules. So in the glomerulus, you have your different kinds of GN, lupus, post-infectious, membranoproliferative cryoglobulinemias, the small vessel disease, your TMAs, small vessel vasculitis that affects the juxtaglomerular apparatus. Most often seen in the hospital setting is ATN from drugs, toxins, rhabdo, contrast. You have your interstitial nephritis, and then intratubular obstruction from drugs, again, like acyclovir or crystalluria, cast nephropathy. And then you have post-renal obstruction, which could be in the kidney or outside, again, bladder outlet obstructions, papillary necrosis, or from outside, like retroperitoneal fibrosis or any kind of tumors obstructing. In the hospital setting, your chunk of AKI etiology is ATN. There's significant amount of pre-renal. There is also some acute and chronic renal failure, but majority of them are ATN. Having said that, AKI in a hospital setting, if you see any of nephrology notes, there's never one specific cause. It's always pre-renal versus post-renal versus drugs versus AIN. That's because these syndromes, as you can see in this picture, all overlap. So your classic patient on 10B with heart failure who's being diuresed also has a UTI and is possibly obstructed, and you've started some new medication because it's possible to have an AIN. So it's important to remember that there's often more than one cause involved in a hospital setting. So what I'm going to do is talk quickly about pre-renal and post-renal, and then we'll go over some of the syndromes, which are mainly intrinsic renal causes of AKI. So pre-renal AKI causes can be volume depletion from whatever reason, decreased PO intake, diarrhea, decreased effective blood volume in your heart failure, cirrhotics, nephrotic syndrome, sepsis, renal vasoconstriction from hepatorenal syndrome, again, hypercalcemia, drugs like NSAIDs, or any altered intrarenal hemodynamics. The key here is to maintain blood pressure and not cause aggressive blood pressure control, which can often worsen the existing renal injury. So as you can see here, when there's decreased absolute or relative effect intravascular volume, there is stimulation of their ACE, angiotensin II, and norepinephrine, which causes vasoconstriction, decreased renal blood flow, and decreased GFR. Again, talking a little bit about the pathophysiology, why do you see low urine sodium, high urine osms, and increased BU and creatinine in pre-renal AKI? It's because when there is decreased blood pressure in your efferent arterioles, RAS activation happens. You have increased tubular reabsorption of sodium, so your urine sodium is less than 20. On the other hand, there's also ADH stimulation, which causes water absorption. So there's high urine osmoles, and there's increased urea transporters in the tubules. So you have increased urea absorption and hence high BUN and creatinine. How do you treat pre-renal AKI? Volume resuscitation is the key. You have two kinds of fluids, crystalloids, colloids. Really, we don't recommend unless in specific situations, which I will talk about later. Crystalloids can be buffered solutions or balanced solutions, what we call, which is your lactated ringers and plasmolite, or you could have saline. There's more and more evidence now that, buffered solutions, which is lactated ringers, is much more preferred over saline because, with normal saline, as you can tell, there's 154 milliequivalents of chloride, which can cause hyperchloremic acidosis. And hyperchloremia, on the other hand, can worsen hyperkalemia. The key in these patients when you do volume resuscitation is frequent monitoring of their clinical status, because if these patients get overloaded, they do much worse. I like this slide because it kind of summarizes the whole, how do you treat pre-renal AKI? So on the left side here, what you see is hypovolemia. So you have your patient who is hypovolemic. What's the preferred agent? What you see in yellow causes more harm than benefit. Those are the colloids, HEAs, gelatin, which is no longer available. And there's your isotonic saline, which is leaning more towards the harm side. And there's buffered crystalloids and albumin. Okay. Once you start resuscitating them, you monitor them very closely. Once they reach euvolemia, then you again monitor for signs of hypoperfusion. And if they've responded to fluid adequately by increasing their urine output, then you can continue administration. However, if you see that they've attained euvolemia, but there is no real, no real signs of improvement in terms of urine output or improvement in serum creatinine, then you should just discontinue the fluids. When you assess them, you notice that they're becoming hypervolemic, then you can start diuretics. If they don't have diuretic appropriate response, then you can increase the dose of diuretics, or if their serum albumin is less than 2, you can give them albumin with diuretics. Any questions so far? Feel free to write it in the chat, because like I said, it's a really big topic. I'll have a few minutes at the end for questions as well. So the next thing we'll talk about is obstructive uropathy, or your post-obstructive causes. Like we went over most of this, the upper tract obstruction and the lower tract obstruction. How do you manage? And what are the clinical symptoms? You see pain, hematuria, decreased urine output, suprapubic fullness on clinical exam, which is a very good bedside test, or suprapubic, tenderness. On labs, you will definitely see increased serum creatinine, and it causes distal RTA with hyperkalemia. The best test to diagnose obstruction is ultrasound. It is one of the high value care tests. You have, it's safe, it's effective, and low cost, right? If your clinical suspicion is really high, you can obtain a CT scan, especially for stones, then you can do a non-con CT for diagnosis. How do you treat? I mean, this is very simple. Relieve the obstruction. If you see someone has retention, or you suspect retention, you can always put in a catheter, see if if there is urine output. The key, if they have bilateral hydronephrosis and you're having a hard time with IR or urology, always feel free to call nephrology, because we can escalate it, because the key is to relieve this obstruction within a week, because that's when you will see complete return of renal function. Because if you have prolonged and complete obstruction, there's tubular atrophy and the renal injury becomes irreversible. So when you put in a Foley, if someone's obstructed and you decompress, the old school teaching was to do a graded decompression. We were taught to kind of do it very slowly. You drain a liter, clamp, drain. But now there's no real data to support clamping. The one thing you have to watch out for is transient hypotension. And with post-obstructive diuresis, you often lose electrolytes. You lose potassium, magnesium. And when you relieve an obstruction, your urine that you put out is equivalent to half normal saline. So basically you're putting out more water and less salt. So what you'll see is hyponatremia. So the replacement fluid should really be half normal saline or hypotonic saline. And the way you replace it is 1 cc of output with half cc of hypotonic saline. Talking about the intrinsic renal disease, I see some questions in the chat. Do you want me to address that now, Chiefs, or do you want to do it at the end?
Whatever you prefer, Dr. Shenoy. If it's not too disruptive, it might be helpful to address them now.
So Nadeem is asking, if for pre-renal AKI in the hospital, I've seen bolus of normal saline, but is there a better fluid than isotonic saline? Yes, LR is better, but if you notice that the patient is dry as bone and they're really dehydrated, you can start with normal saline. You can give a bolus and then switch to LR. There's no harm with that. But the preferred fluid is definitely a crystalloid, buffered crystalloid. So intrinsic kidney disease, like I said, that there's a lot of important things to talk about here. I'm not going to talk about the glomerulopathies because that's a different topic altogether and should be another lecture, but I'll talk about the syndromes that we often see on the wards. So contrast controversy. In the past, there was always topic about contrast-induced nephropathy, be careful with the contrast. But the initial studies that was in the 70s and 80s on CIN were uncontrolled, and they often overestimated injury. So what happened as a result is that patients who really needed contrast studies were not getting them. So, ACR, which is American College of Radiology, came up with this definition, which most nephrologists agree with as well, is that contrast-associated AKI, formerly known as post-contrast AKI, is a general term used to describe a sudden deterioration in renal function that occurs within 48 hours following the intravascular administration of iodinated contrast. It does not mean that the contrast itself has caused injury. Remember from the initial picture that I showed that these patients in the hospital have a lot other things going on, not just, you can't just blame contrast for the injury. And also remember, gadolinium-based contrast media, they do not cause contrast nephropathy, but you have to be careful in giving gadolinium, the older gadolinium. Now we have the newer ones which are okay with end-stage renal disease patients, but the older ones were not. What are the risk factors for CIN? You have, decreased GFR to begin with, volume depletion, comorbid conditions, patients who've received NSAIDs or other nephrotoxic agents. And the pathophysiology is very simple. It's vasoconstriction and direct tubular injury. So how do you prevent CIN? Again, data is not very strong. Fluid administration, if you can, and if the patient appears hypovolemic, again, isotonic fluids, a normal saline is preferred in this setting for prevention. Obviously, hold your metformin for 48 hours. Holding ACE or ARB, NAC, statins, none of that has been recommended. I want to quickly talk a little bit about AKI and COVID-19 and what the pathophysiology is. This is, well, basically AKI, we've seen a lot of AKI in COVID patients. So it could either be pre-renal hypovolemia from fever, insensible losses, or we know that the SARS-CoV-2 really has an affinity for the ACE2 receptors, which is really expressed in the kidneys in large volumes. They cause a cytokine release and can cause hypercoagulation, causing thrombotic microangiopathy, can cause rhabdo and cause myoglobin cast nephropathy, and obviously circulatory collapse from ARDS and sepsis and acute tubular injury. And there have been reports of some collapsing glomerulopathy as well. Let's talk a little bit about rhabdo. So rhabdo is basically muscle injury causing release of myoglobin and subsequently kidney ischemia and tubular obstruction. Almost 40 to 45% of those with rhabdo. Now, when I say rhabdo, the real rhabdo is CK level of more than 5,000. So anything that's in the 7 to 100 to 1,000 is really not rhabdo. Having said that, our CDQI and documentation colleagues prefer to have that diagnosis in the chart, but what I'm talking about is from a clinical setting on what is a risk factor for AKI. So rise within 12 hours, CK, you see that it'll start rising within 12 hours of injury. It peaks between 1 to 3 days, and in 5 days, it usually normalizes. Your classic UA is positive for heme, no RBCs, because myoglobin cross reacts with heme on the dipstick. Treatment again is fluid repletion until CK is stable or coming down. You can start with 1 to 2 liters of isotonic saline or LR. But the better thing is to do LR. Initially, you will not see so much volume overload, but as you give them more and more, you'll see that they may develop sequestration of fluid within the damaged muscle. So what you have to really watch out for is compartment syndrome. What is the indication for bicarb drip in this patient? Only if there's no hypocalcemia, because remember, metabolic alkalosis worsens your hypocalcemia. If serum pH is less than 7.5 and serum bicarb is less than 30. Alternately, you can also monitor the urine output. And if the urine and the pH target for urine output, pH target in your urine is more than 6.5. If there is no rise in the urine pH over the next 2 to 3 hours of starting bicarb drip, then there's really no point in continuing. You can switch back to LR. Again, continue fluids until less than 5,000 and monitor electrolytes, mainly hypocalcemia. And hypocalcemia, calcium should not be repleted unless patient is symptomatic, because again, if you give calcium, it's going to get deposited in the muscles. And dialysis does not remove myoglobin. Acute interstitial nephritis, so the causes are several. We're kind of always thinking about AIN in terms of drugs, but remember, systemic illnesses like your Sjogren's, other infections, and there is Teno syndrome, all these things can also cause interstitial nephritis. The list is really extensive. The most often the common agents are your cephalosporins, penicillin, ampicillin, PPIs, NSAIDs too sometimes. So it's an extensive list. You should suspect AIN when there is rash, when there's fever, when there's eosinophilia, and peripheral eosinophilia on your smear. And again, your urine will have this typical white blood cell cast. So how do you manage drug-induced AIN? So if you're suspecting AIN, first thing to do is identify and withdraw the offending agent. So see when the creatinine is starting to creep up, what was introduced around a day or two prior to that, and remove the offending agent, and then give supportive care and monitor the kidney function over the next 3 to 5 days. If the patient's kidney function is improving, fantastic, just continue to monitor. However, if it's worsening, then you definitely need a kidney biopsy, because the treatment for AIN is steroids for a long time, and you don't want to give them steroids unless you have a definite diagnosis. If there is AIN on the biopsy with less than 75% of fibrosis, then there is some point in giving steroids, because that should help. But if there's more than 75% fibrosis already, the damage is done, then really there's no point in giving steroids. You do conservative management. But from a medicine standpoint, if you should really take out the offending agent, see if it's improving, fine. If not, then then have a nephrology consult, because these patients really do need a biopsy. So cardiorenal syndrome, again, there's different types. I'm not going to go into the details of it. There's 5 types of CRS. Basically, again, what you really have is sort of a neurohormonal induced decreased blood supply to the kidneys, and mimics pre-renal. So if the patient is not on a diuretic, you'll see decreased urine sodium. If the patient is on a diuretic, you should really get a urine urea in these patients. The other important one that, syndrome that you'll see in patients, mostly cardiac patients, post-cath, is cholesterol crystal emboli, causing renal manifestations and, elevated CK. In these patients, you'll see this kind of a rash that you see here on the right side. It's called livedo reticularis. So anyone post-cath, if you see that, their kidney function is getting worse, one thing, it could be contrast related, but if you see this kind of a rash and see other things like, they have cutaneous manifestations and they had extensive plaque, it was a difficult angioplasty, then you should really keep cholesterol emboli in mind. And in these patients, complement levels tend to be low. AKI in liver disease or your hepatorenal syndrome. So the pathophys is mainly portal hypertension, causing increased nitric oxide production, vasodilation, and decrease in systemic vascular resistance, and causing, renal hypoperfusion. And again, you'll see low urine sodium. So there's 2 types. I think it's important to know the difference here. The first one is type 1, where there's more than 50% reduction in GFR to a creatinine of more than 2.5 in less than 2 weeks. And these patients are often very sick and oliguric at the time of onset. And type 2 is more of a, insidious onset, and their ascites can be resistant to diuretics. Remember, it's a diagnosis of exclusion. Just because someone has cirrhosis doesn't mean they have HRS. They could also be volume deplete, and they could be pre-renal. Treatment is to increase their MAP. If they're critically ill in the ICU, you could start pressors. If they're non-critically ill, first thing to do is withdraw diuretics and then midodrine and octreotide. Again, I'm not going to go over this slide because it's pretty much the same. And in these patients, often, if they're candidates for liver transplant, will do dialysis as a bridge to liver transplant. Often when patients get a liver transplant, if their kidneys were fine to begin with, then we don't really assess for kidney transplant. But if they had some other reason to have stage 4 CKD that's not hepatorenal, these patients get dual organ transplants. So a little bit about onconephrology. I know we're seeing more and more oncology patients. So patients with malignancy can have either pre-renal, intrinsic renal, or post-renal AKI. Pre-renal, it could be from volume depletion, hypercalcemia, pain meds. Intrinsic can be several. You could have lymphoma. In lymphoma patients, you could have infiltration. Tumor lysis is very common. Cast nephropathy in your myeloma patients. And post stem cell transplant, you'll see TMA is common, and they can also have toxicity from the immunosuppressants like calcineurin. And post-renal can be obstruction. What you're seeing here is your myeloma kidney, an image of your myeloma kidney, myeloma cast in the kidney. So how do you evaluate patients for AKI? You look for their volume status. You have to look for intravascular volume depletion. You ask them if they're thirsty. Look at their mucosa, kidney, urine output, any cause for excessive fluid loss, fluid balance. And on physical exam, look at their skin turgor, look at their, JVP, and most important bedside test is doing orthostatics. See if they're, more than 10 increase in pulse rate or fall in blood pressure of systolic blood pressure more than 20 after standing for a minute. And then obviously you also have to assess for volume overload in patients with CHF, look for, your swelling, edema, JVD, crackles, third heart sound. Besides that, some of the other things you want to look at on clinical exam, which are related to the AKI syndromes, is on the skin. You'll look for livedo reticularis, which you'll see in patients with either a cholesterol emboli, purpura in case of systemic vasculitis, diffuse rash in allergic interstitial nephritis, or if they're using any kind of substances, you'll look for track marks, especially endocarditis causing post-infectious GN. In the eyes, your HRS patients can have jaundice, band keratopathy. I haven't seen one. In hypercalcemia, in keratitis, uveitis, in patients with Tinu syndrome. Alports, again, these are all rare, but it's good to know, especially for your boards. Alport syndrome causes hearing loss and AKI, and so with aminoglycoside toxicity. Remember, high doses of furosemide can also cause hearing loss, but it's transient and there is reversal. Cardiac exam, you want to look at any rubs, irregular rhythms to see if there is AFib that can cause thromboembolic disease, again, endocarditis, and your S3 and increased JVD in patients with heart failure and cardiorenal syndrome. Pulmonary renal syndromes, you have your good pasture, other types of vasculitis, and now we're seeing more with COVID, ARDS. You'll see your typical rails and, on physical exam, and abdominal exam again. Mostly you'll see on post-renal, you'll see a suprapubic fullness or CVA tenderness if they have nephrolithiasis or pyelonephritis. And in rhabdo, you can see some edema or ascites if you've given them too much fluid. So what labs should you order? Remember to choose wisely when you order these labs. Any AKI that I've seen in the hospital, there's always a bunch of urine lights ordered and no one's assessed them. And most often it's the timing is not right. And we're just spending dollars on getting these tests, which no one's going to interpret. If you have a patient you're seeing in the emergency room and the picture is very clear, this patient is from a nursing home, hasn't had any fluid in the last 3 days and has AKI and just looks very dry, has high sodium, has high calcium, you don't need to send urine electrolytes. You can just, start the patient on fluids and you will see an improvement. If you don't, then we can start working them up. You definitely need to send a UA, if there's an infection or anything to rule that out, but you don't need to send urine sodium, urine eosinophils. That is really not indicated. It's not even a specific test for AIN. Renal ultrasound, definitely, it is really the recommended test because of its cost effectiveness and safety. Again, depending on the clinical picture, not everybody who has an AKI needs a renal ultrasound. If you give them fluids, they're making urine, kidney, your creatinine is coming down, they don't really need another ultrasound. And check your CK level, uric acid, and if they have proteinuria, and if you're suspecting some intrinsic disease from a glomerulopathy, then obviously work up for causes of proteinuria, which includes your Hep B, Hep C, HIV, complements, ANA, and phospholipase A2 receptor antibodies. So when you have to get urine lights, what should you get? If, like I said, if the AKI is not improving, then you get urine sodium. Awesome. But remember, when you get urine sodium and urine osm, get it all together at the same time. Don't, if it's done a day later, it really doesn't help with interpretation. If patient's on a diuretic, get the urine urea to calculate fractional excretion. Urine protein to creatinine ratio in AKI is ideally not recommended until the creatinine is stable, because if they have ATN, they could leak protein from the tubules. For hypo or hypernatremia, again, urine electrolytes, urine osm, and urine creatinine, send them at the same time as a BMP. Urine chloride is often to diagnose your RTAs in non-iron gap metabolic acidosis, and sometimes in metabolic alkalosis to see if they're chloride sensitive. And hypomagnesemia, you can send some urine mag. But remember that these tests, you have to interpret in the right clinical setting and not just go by just those numbers. When you see urine tests and you want to make sure that it was done before fluids were given, was it done right after Lasix was given, so make sure you interpret in the right setting. So in your pre-renal, you'll see a high BUN creatinine ratio, and we discussed why earlier. Urine sodium is less than 20, your FeNA is less than 1, you have a very high urine osmolality because of elevated ADH, and your urine is bland, there's no protein, there is minimal protein, there is no CAS. In the post-renal, again, you have high BUN to creatinine, urine sodium is variable, FeNA is more than 1, and urine osmolality is low, especially if you put in a Foley and there's obstruction, then urine osmolality is really low because, like I said, you're putting out half normal saline. With ATN, again, the BUN to creatinine ratio, they say is 10:1. Urine sodium is more than 20, FeNA is more than 1. Urine osmolality is 250 to 300. And what you see is your classic muddy CAS. Acute GN, again, FeNA is your BUN to creatinine ratio is more than 20. FeNA can be less than 20 or more than 20 is variable. Urine osmolality as well. And you'll see dysmorphic RBCs and RBC CAS. And in the AIN, you'll see white cells, WBC CAS, eosinophils, again, may or may not. So do not send urine eosinophils if you're suspecting AIN. It's very easy to spin urine and take a look under the microscope. Anyone who's done a renal service with me knows how to do it. And if you're interested, always reach out to us or the renal PAs, and we're happy to show you how to do it. It's we go down to the first floor. It's a quick thing. You spin urine and you look it under the microscope. Sometimes you can get good diagnosis from just looking at the urine. Supportive management of AKI. So, if there's volume, we talked about it. If it's pre-renal, you give fluids. If there's volume overload from not improving, then, you restrict water, restrict salt, give diuretics. And if nothing works, then of course there's dialysis or ultrafiltration. Hyponatremia, again, if it's hyponatremia and AKI is often related to increased fluid. So you restrict free water intake. Hyperkalemia, dietary, watch their diet, make sure, your patients are on the right diet when they have AKI and hyperkalemia. Lokelma is the preferred agent for binding. Glucose and insulin, in patients who have AKI or CKD, never give 10 units of insulin. It's always 5 units with 50% of dextrose. And that's because insulin lingers in for a longer time in these patients. And you may give a 50% dextrose and 10 units of insulin. And, 2 hours later, patient's unresponsive because they're hypoglycemic. So always start with 5 units of insulin. And that's IV insulin. Sodium bicarb, not very helpful. Studies have shown that, sodium bicarb is good when it's given in a sustained drip versus pushes, or in a standing oral dose. Beta-2 agonist is not helpful, and calcium gluconate is really given for stabilizing the membranes to prevent adverse cardiac outcomes. Metabolic, if you notice metabolic acidosis, you should start them on either IV, or you can also do PO bicarb. Hyperphosphatemia, decrease their phosphate intake. Phosphate binding agents, depending on the calcium, you can use calcium acetate or sevelamer. Hypocalcemia in AKI, we often replete only when they're symptomatic. Otherwise, there's really not necessary to replete them with calcium gluconate. Hypomagnesemia or hypermagnesemia is what you see, and discontinue magnesium-containing agents. Hyperuricemia, you can start allopurinol at a lower dose, or if it's TLS, there's always rasburicase. Remember to send your G6PD levels in patients before giving them rasburicase. And nutrition, nutrition support as well. Treatment for AKI, again, just to summarize, eliminate the insult, hemodynamic support, avoid chemical nephrectomy. So just don't allow for aggressive blood pressure control. You can leave their blood pressure 140 to 160. Fluid and electrolyte management, adjust the dosage of medications. If your creatinine is going up, take a look at medications. Often you'll see that patients are on gabapentin or Lyrica, and this is what I commonly see on the wards, and they'll be on high doses and not adjusted for creatinine. You'll see tremors or altered mental status. So if you notice your patient's creatinine going up, adjust medications, all medications, to their GFR. And, if conservative management doesn't fail, there's always dialysis, and the indications here: uremia, hyperkalemia, volume overload, and severe metabolic acidosis. Yeah, that's about it. And I'll take any questions.
I have a question about the bicarbonate drip for rhabdomyolysis. Does the patient necessarily needs to be in the ICU for that?
For bicarb drip?
Yeah.
No, it can be done on the floor.
Okay.
It can be done on the floor. Bicarb drips are done on the floor.
I have a quick question. There was that slide that talked about the different lights that we should check for different electrolyte disturbances. Yeah. One of them was like for the hyponatremia and stuff like that. Yeah. Can we still order those lights, and how are they affected if patients have already been started on fluids, like when they're in the emergency department? How do we work around something like that?
Yeah, so it's a very good question. Often when we see these patients, they've already gotten a bolus of normal saline, and it's not useful. However, if their sodium is coming up, if their sodium remains low, continues to remain low after giving them normal saline, then you want to work them up, then it's useful, to do those sodium urine lights in that case.
Thank you so much, Dr. Shenoy, for a truly interesting lecture. I'm sure if anyone has any more questions, I'll post them in the chat or email us about them. Hopefully we can forward those questions to you.